Acute abdomen and surgical gastroenterology. So pain is the most common symptom of all GI diseases. It may be acute, chronic, or recurrent. Acute pain is persistent and is of recent onset. Acute pain in the abdomen is identified acute abdomen until a precise diagnosis is made. And the exact cause of an acute abdomen is difficult because there's 8 different organs that are mixed into a single cavity we have to take into consideration. So be sure and observe the patient's general appearance. Look at the mental state of the patient. Look at their appearance or their comfort level. If they don't appear to be in a lot of pain or discomfort, well then the pain is not usually of a serious nature. Now, if the patient appears to be anxious, they're pale, they look like they're in obvious pain, they're fidgeting around, they're not able to get comfortable, then you got to consider that there's the possibility of a real serious problem. Now, chronic pain is pain that persists over weeks to months, and this is very typical of cancer presentations. And then the third pattern, recurrent pain, is typically intermittent. And it may be present for a while and then it may leave for a period of time only to reappear and then become absent again. So when looking at abdominal pain, we have to keep in mind that we have 2 types of visceral organs. We have hollow organs such as the stomach and the GI tract, and then we have solid organs such as the liver, the spleen, the pancreas, as well as the kidneys. Now with hollow organs, these organs, they empty by muscle contraction. So the typical pain presentation is going to be a waxing and waning pattern, like a crescendo, decrescendo type of wave pattern, like peristaltic activity, for example. Now solid organs, like previously mentioned, they typically produce a constant pain when they are the pain generator. So visceral pain is pain that originates from the abdominal organs or the viscera. This type of pain responds mainly to the sensations of distension and muscular contraction. Visceral pain is typically vague, poorly localized, tends to be dull, nauseating, a cramping in sensation. This pain typically tends to be perceived in areas that are corresponding to the embryonic origin of the affected structure. So if you think about it, the stomach, the duodenum, the liver, the pancreas, they would all produce upper abdominal pain. The small bowel, proximal colon, and appendix would typically produce periumbilical pain. The distal colon as well as the genitourinary tract will typically produce lower abdominal pain. Typical presentations. Now somatic or parietal or muscle wall pain, it typically responds to irritation from infectious, chemical, or inflammatory processes. It's typically sharp and well localized. Colic is a type of pain that is a spasm or a cramp, and it's characterized by intermittent sudden attacks, and those sudden attacks are identified as paroxysms. And these are of a crescendo, decrescendo type pain that typically arises from hollow organs. Now the intensity of the colic pain will vary with the circumference of the lumen of the area that's affected. What's typically seen is that the smaller the circumference, the higher the pressure inside the lumen and the greater the pain. The larger the lumen, the less amount of pressure, therefore the less pain. Now, referral pain is pain that's perceived distant from its source, and it results from a convergence of nerve fibers at the spinal cord level. Now, peritonitis, this is just a brief overview. We will talk about it in more detail later in the course, but peritonitis is an inflammation of the peritoneal cavity. Its most common cause or etiology is from a perforation in the GI tract. Now, peritonitis produces an immediate chemical inflammation, and then this is followed shortly by an infection. A secondary infection develops from the intestinal organisms that are proliferating. Now, peritonitis can also be caused from any abdominal condition that produces marked inflammation. Peritonitis will cause fluid shifts into the peritoneal cavity and into the bowel, and this will lead over time to severe dehydration as well as electrolyte disturbances. So this condition can actually lead to respiratory distress, kidney failure, and liver failure. So let's move into the presentation of a diffuse abdominal pain presentation. So when a patient presents with a generalized diffuse abdominal pain presentation, there's an initial series of differential diagnoses that need to be considered. They include acute pancreatitis, an early appendicitis, gastroenteritis, that's an inflammation of the stomach and the intestines, intestinal obstruction, and then the final differential is a peritonitis, where we have that inflammation of the peritoneum. So these are conditions to consider based on abdominal pain location. Start with the anatomy. Think about what would be located in the area of pain from a local pain perspective, then moving out to referral pain and encompassing the physiology. So we always start with the anatomy and move our way outward, so to speak. So when looking at right upper quadrant pain, it's important to think about what structures are close enough within that area that could produce pain. So the list that I have on this slide is not inclusive, it's just a good starting point. When I think right upper quadrant, the first thing that comes to mind is liver and gallbladder. So I'm going to go with things like cholecystitis, biliary colic, hepatitis, or liver disease. Also, I'm going to be thinking about the proximity to the pancreas, so pancreatitis, the proximity to the stomach, so things like a perforated duodenal ulcer, not unreasonable, based on where the perforation occurs and the severity of it. With the presence of left upper quadrant pain, thinking stomach, spleen, duodenum, pancreas. So things like gastritis, splenic disorders, abscess, rupture of the spleen, peptic ulcer disease, pancreatitis again. Now with epigastric pain, that can also be referred to as right or left upper quadrant pain, I'd be thinking initially pancreas, stomach, lungs, heart. So things like acute pancreatitis, lower lobe pneumonia, myocardial ischemia, possible herpes zoster could be feasible in this area, radiculitis, as examples. Now, when I think about right lower quadrant pain, one of the first things that come to mind is appendicitis. Also, things like diverticulitis, proximal colon involvement, distal small intestine involvement, on females, ovarian disorders, as well as fallopian tube disorders, and then possibly pelvic inflammatory disease. So with left lower quadrant pain, number one, I'm thinking about descending colon disorders, sigmoid diverticulitis, in females, ovarian disorders, as well as fallopian tube disorders again, and I could also throw pelvic inflammatory disease back in here again. And lastly, looking at right and or left lower quadrant pain, as well as just centralized lower abdominal pain. Abdominal wall problems like sprain or strain, cystitis, an inflammation of the bladder, endometriosis, as well as pelvic inflammatory disease for females, inflammatory bowel disease, possible Mittelschmerz, which is defined as pain during ovulation for females, possible referral pain from renal stones or kidney stones, also abdominal aortic aneurysms, and for females, possible ectopic pregnancy if they're in their childbearing years, and then the possibility of torsion of the ovary or an ovarian cyst on females and testicular torsion on males. So we've got a lot of different conditions and we have to consider in this area reproductive disorders as well that could play into the pain presentation.